Okay, everybody. So, welcome to week two. And the first thing I want to do is see how week one went. So, for instance, uh, did all the links work? Were you able to navigate D2L? How did the Dropbox go for the discussion board? Did you have any questions about the syllabus? How'd it go? All right, I see a few thumbs up. I'm going to take that as a resounding A-OK. And yeah, but if you had any more questions about the syllabus, so remember, most of our assignments are discussion boards. That's a huge part of your grade. And I think it's more interactive as well. And hopefully um not too time consuming. Uh, but the only other assignment we have is that final assignment. So we're going to talk about that uh, probably next week or the week after. So you'll have a few weeks to work on that. So it's not like you're not just working on it the last week. So that'll give you a little more time. The crazy thing is, in most classes, um, students say, "Oh, it's the second week," and it's like we're just getting started. But when you only have 7 weeks, like the second week, we're already well into our semester. Um, so it's a lot to squeeze in 7 weeks. So um, all right. So the first thing I'd like to talk about is things that you went over last week, and then we'll talk about new things for this coming week. Okay. So the first thing is um, being sane in insane places, and it is a famous article, and I just want to first of all, get your reaction on, and believe it or not, um, this is not, this was not the first time that they did a study where they had false actors in uh, uh, inpatient facility. This was also done by a reporter almost 100 years ago, and um, and that's a pretty famous one too. But it's pretty old. This is more contemporary. And so, first of all, I want to get your reaction to what happened, and and then we'll talk about the ethics behind it. So, what's your reaction? Just a general reaction to the article, and then we'll talk about whether it was ethical or not ethical, why it might not be ethical.
I'll just say I thought it was like really sad and disappointing at like how these professionals were treating the patients. Just like the lack of care and like even just noticing them or acknowledging them, I thought I don't know, it was just really sad, especially because like these are populations that like really need to be protected and helped and they I feel like they're doing the complete opposite. They're just drugging them up and then letting them walk around like zombies rather than like actually giving them the like time, care, and attention that they need. So I was just like, I was saddened by it.
And I think it was really interesting how the author pointed out that like the system kind of like trickles down and creates that disconnect between like care, like patient care, and like what their actual goals are of treatment. Because none of us go to school to ignore our patients. So it's interesting that these people with similar backgrounds to us go to these jobs and end up giving poor care because of the environment that they're in.
Yeah. Yeah, so that's kind of the main setting. Why do you think this happens? Like when you said it kind of trickles down to this, why does anybody think this starts to happen institutionalized settings?
I guess it could be burnout.
I think that's a good guess because um, I it is a stressful situation. Um, and when you're dealing with patients that have more severe diagnoses and you know, having to call services to restrain individuals properly and gently, but still, it's still stressful and scary. And I know today, so when I started in an inpatient facility years ago, this was before they had like portable panic buttons, but they had just invented the radio controlled doorbell. So you didn't have to run a wire from the doorbell to the house. So if you had like a fence or a gate, you could put on this doorbell and there wasn't any wire to the house. You press it and it rings in the house. And so I used to carry around one of those doorbells and the main desk would have the ringer and so if we clicked the doorbell they'd know we needed help and had an emergency. So it was a very primitive thing. Now we have wristbands and it has a button on it. And one time I had the wristband in my jacket pocket and I sat on it by accident. And I had like 10 people there in like under a minute. And so I'm like, it made me feel pretty good that they cared about me. Um, but uh, but now it's hopefully a lot more safe for individuals. And Gracie, you had your hand up?
Just like feeding off of what Deborah was saying, I feel like most likely the staff isn't getting like emotional support that they need for dealing with these severe cases. So I think that probably feeds into like why they are more neglectful, I guess.
Yeah, like now, one of the things that Mark Lepore, another professor here, specializes in is he goes around and debriefs with all the nurses and other personnel in different departments. So, for instance, if they've experienced a death or trauma or anything like that, he can debrief with the whole staff of whatever unit he's on. And that's one of his specialties. And I think that debriefing really helps, especially if there's like when we work in the Red Cross, we do what's called, I go over this if I teach crisis and trauma, um, but we do what's called CISD, critical incident stress debriefing, and where we hold groups and that's not just for victims but that's for emergency service personnel as well who react to emergencies. um, so for instance if we went to a shooting uh, immediately after it happened. Sometime within a day or two, we would get together and debrief uh, because that's called secondary trauma, or um, you know. So I think that is really important. Um, okay, so let's talk about uh, so they had all of these individuals who were impatient, and when they interviewed, they gave one, maybe two symptoms that met the criteria for schizophrenia, and but after they were admitted, they did not share any. They did not display any of the symptomology or meet any of the criteria. So what happened with that? Uh, why did the staff think they were still diagnosable? or displaying symptoms. So if they did something like take notes, yeah, Butch, you don't have to just speak up. You don't have to raise your hand. Go ahead. What were you going to say?
I was going to say, I almost think that it's like there's a permanence to diagnoses like that follows you around forever. And there's also just like confirmation bias of once somebody showed that symptom, they have that like abnormal label for the rest of their lives, and all of their behavior will be judged by that standard forever after that.
Exactly. So it really becomes a bias. So anything that's observed, like things like maybe they were taking notes, and really they were writing down what they saw and it was real, but they saw that as part of the criteria for the diagnosis, excessive note taking and journaling, and they thought they were, might be conspiracy theory. Who knows what thought they were writing? But you know, uh so anything they did that was even part of the study, they saw that as, part of the diagnosis. All right. So what were some of the things that happened that would make this an unethical study today? Why couldn't we do this study today?
I'm sure there's a lot of confidentiality breaches there. Patients coming in, reporting on what they saw.
Yeah, they could breach confidentiality. It's possible. They could simply, agree to no name designation or anything like that to keep everything anonymous, but it may not be HIPAA compliant or something like that. They didn't actually work for the agency. So it's a little different. Uh, what else could happen?
Well, there was
Was
no informed consent. Sorry, go ahead.
I was gonna just mention how the person who was conducting the study also participated, which could have helped skew the results.
It could have skewed the results. Um, the so could anybody have been harmed?
That's what I said in my post, how not only is there a chance of like physical harm, also like severe psychological harm to these people that like haven't experienced too many traumatic events like this alone. Being in that kind of environment, I think could like do enough damage. So yeah, I 100% think that harm is like a very real possibility.
Yeah, so both of the things you mentioned, Gracie, what else could cause harm?
I thought about too, kind of like what Gracie was saying. Weren't they given medication, but they spit it out? But it's like they're giving this treatment they don't really need, and especially like medication that could do some harm there.
That's the main reason it's unethical is because taking psychiatric medication when it's not your diagnosis could cause all kinds of harm. And even though they say they spit it out, there's no way the patients I deal with can spit out medication. So if it's pills, they can check their mouth. But most of the time, if they act as if they're resistant to medication in any way, they give it in a shot form. So there's really no denying that or resisting that. So the medication is the number one reason. The second reason is a little different. So let's say they accepted 3 or 4 people who did not have a diagnosis, and all the beds were full on the unit. But 3 or 4 people who did have the diagnosis were having a psychotic episode and they couldn't get in the hospital because all the beds were full. So taking on these 4 people who didn't need treatment would deny treatment to 4 people who did need it. So that's another way it could cause harm. So they wouldn't be able to admit as many people as they could if these individuals were not doing the study. What were some of the things that the nurses were doing or the aides were doing? Because the word I like to use with this study is basically it revealed dehumanization of patients. So what were some of the things that maybe the nurses or the other staff were doing that might give you a feeling that the patients were dehumanized?
They basically ignored them the whole time.
So they did, you're right. How did they ignore them? Like, what are some of the things that might be a clue?
Well, in the article, it said that they would go up and ask to speak to somebody, and it like showed in a chart how many times they actually got a response, or if they just kept walking, or even if they got like a facial turn, like some sort of acknowledgement that they heard them.
So literally ignoring any attempt to communicate. Yeah. Okay, so that's the most obvious. Good. What other things did they do that had to do with ignoring them, but also kind of dehumanizing them? Like it talked about nurses adjusting undergarments as if the people weren't there. Whereas if you had the same people there, but they were sitting in a restaurant instead of a psychiatric facility, they would never do that. They would be embarrassed to do that. But they were so dehumanized that it didn't bother them in the least to do that at the nurses' station. So one of the things that occurred after this study was there was a lot of revision in hospitals. Hospitals basically were afraid that there might be a study at their own hospital, you know? So they didn't want to take a risk. And there were investigations and observations at all of the various hospitals. So the other thing that happened was much more use of antipsychotic medication, which really took off after this article. And the result of antipsychotic medication is that it won't cure anybody. People, you would still know that they had some kind of diagnosis, but they could become independent. So they would still be struggling, but with a caseworker, they could live somewhat independently or at kind of a, rather than a hospital, in a supervised home where there were residents, but they had a little more freedom. And so what happened was there were massive closures of state-funded hospitals. And it didn't quite go as planned because the number of people experiencing either schizophrenia or some type of extreme trauma, like due to the Vietnam War, the number of homeless people with mental illness really rose because they did not want to be, in a home or even an apartment and they ended up being homeless because there were so few hospitals. So many hospitals even closed around the Pittsburgh area that now most regular hospitals have a very difficult time finding a bed for a long-term inpatient facility. So what's happening now is because so many closed, the number of homeless individuals with diagnoses increased dramatically. But also, if an individual goes to a regular hospital and they go to the psychiatric unit in that hospital, the stay used to only be 30 days or less because they wanted to stabilize somebody on medication, and then they would either release them to counseling, release them to outpatient therapy, or release them to a facility. They call it a locked facility, but an inpatient psychiatric facility. Now, people are staying much longer in general hospitals on the psychiatric unit because if they can't be released independently, there are very few beds available in either inpatient facilities or supervised outpatient facilities. And that's really a bind that our system has gotten itself into, mainly due to closures and finances. Because what happens is it is kind of layered, because if people are staying longer in a regular hospital psychiatric unit and they're not able to find a bed somewhere else to be transferred to, then people are even backed up in the emergency room, and they had to make more permanent facilities for emotional disorders in another area of the hospital. And they're just, not getting the same type of treatment as in a psychiatric unit. They're kind of waiting to get into the psychiatric unit. So it really has this effect that it goes through all of the different layers. All right, so that is the article. Any closing comments on the article? Okay. So let me share my screen. So first, I want to look at last week's content in week 1, and then we'll talk about this week's content. So as we go through, we went through the syllabus. We talked about the basic structure of the semester, and I recorded that. So let's talk a little bit about the history of diagnosis and the ethics. Are there any questions or comments? It's a long history, but what I think you need is to remember 2 things from the history for the comps and for the NCE. The first thing to remember is if I mention a name in the notes, that's a name that could appear on those larger exams. So for instance, Frank Parsons, or basically any name that I put in those notes could pop up on those larger exams. The other thing is basically the history of the DSM. I listed some names of organizations uh, and timelines. So just having that timeline and how the DSM came to be. The ethics, you're going to have an entire class on ethics. So I think you'll be fine after that. And we mentioned ethics in most of our other classes, like confidentiality and limits of confidentiality. And that's in skills and theories and a lot of other classes. So I think you'll be okay with ethics after you take the ethics class for the exam. But I did also mention it on that lecture and in the notes. And so let's see. All right. So the other thing, this was a long video. I realized that I tried to divide it up into just basic segments and skip all the segments that you don't need. And you're never going to have to watch any more of that video. Now we're just going to today, we're going to start talking about specific diagnoses. And I tried to find videos from this point on that you'll actually be able to see people with these diagnoses talking about what it's like having the diagnoses. So this was more of a lecture type, but this was an expert on the DSM-5. There's not that much difference between the DSM-5 and the text revision. So what they do is they'll put out the DSM-5 for a few years, and people will submit any changes or mistakes or things that they thought needed clarified. And then that's what they will add to the text revision. So it would almost be like, an edited version of the DSM-5. So there aren't many changes like in the diagnosis criteria or things like that. But what these do is that these give you kind of an introduction. This lecture gives you an introduction to the DSM-5, to the process of assessment and diagnosis. So, I think the part on assessing is probably the most important part. But did you have any questions about this lecture, these sections of the lecture? All right, and then that was your discussion board. So the way the discussion board's going to work is basically, hopefully you all submitted your responses to the material of this past week by today. And hopefully you responded to 2 other classmates as well. If you haven't yet, please do that. So it's all about this group interaction. I want you to read what other people are writing as well, so that, you're not just talking to me, you're responding to other classmates as well. So 2 brief responses to other students, and then I'll spend this week responding to all of your discussion board posts. So, so we'll see how that went. And, I'll be giving you all some feedback. The way I give discussion board feedback is the first few sentences are about your post and only. So it's, I'm responding to you personally in the first paragraph. The second paragraph is a general class response that I paste into everybody's discussion post on kind of my response to the material that you talked about. Things that you should have covered, like an outline of what you should have covered in your discussion post, and any of my thoughts on the material that I didn't share in a lecture or the class. And so, but the first section is about your personal post. And I believe that, if you took the time to write a page or two in a discussion board, a professor should take the time to read it all and give you some personal response. I know sometimes a professor might just give a person a grade with very little feedback. If I put forth that much effort, I'd want some feedback. So I think that's only fair. All right. Anything for last week before we move on to this week? All right, moving on. All right, so this should be open now. You should be able to see week 2. I usually don't want any confusion if people are trying to finish up their discussion boards the last minute. So I usually open up the new week right before the class so that people aren't confused about what they have to read or respond to. And okay, so the most important thing is it's a lot because it's 2 weeks worth of work in 1 week, because it's usually 15 weeks and you've got 7 weeks. So it's exactly 2 weeks of information. All I did was cut it down from 15 weeks to 7 weeks. But I did cut out all of the exams, and I cut out your midterm video assignment. So that should be helpful. Okay, so as you scroll down, usually these things come in sets of 3. There's my video lecture, there's my notes, and then there's a video from the library or PBS. And that's the video that shows an actual client talking about what it's like to have this diagnosis. If you'll notice, it does not stop at dissociative disorders because there's no discussion board. You must click load more, and then you get more fantastic lectures and videos and notes, and it takes you down to the discussion board. It's not that much more. So what I tried to do, every time I look at the syllabus and I look at the different subjects in the DSM, for instance, there's a lot of diagnoses in these sections in the DSM, but I usually try to talk about, I'd rather focus on certain diagnoses in depth than just give a broad overview. So I picked the diagnoses that I think you're going to run into the most as a therapist. And those are the ones I talk about in detail. And you can just read about the other ones. I will say that there's a variety of lectures on here. The oldest ones are kind of pixelated with a fake background. And those are the ones and I have crazy long hair. And those are the ones I'm going to try to record again. I did make sure that all of the videos are at least for the 5TR or the DSM-5. None of them go back to 4TR. So they should all be applicable. There might be a small change in the text revision, like a statistic or something like that. But for the most part, they should be accurate. So as you move through these, the most important pieces of information are actually the recorded lectures. And that's because in the recorded lectures, I focus on what I think is most important to you, the things that you'll use most as a therapist. I think that one of the things I'd like you to respond to in the discussion board is the stories that I tell. So any of the diagnoses that I talk about, I've had clients with that diagnosis, and I have stories about them that I share with you in the video. So just like, what was it like in that article to go into a psychiatric facility? What was going on with the patients? What was going on with the nursing staff and the psychiatrists? So I try to give you a variety of pictures and experiences in the stories I tell you about clients. And I never reveal any identifying information, like there's never any names or locations or anything like that. It's all anonymous, and I'm allowed sharing these stories with you. But I think the stories give you a variety of examples, and some of them they were interesting to me. So I'd like to hear in your discussion boards, what did you think about a couple of the stories? What's your response? What would you have done if that was your client? Would you have done something differently? Have you had a similar experience? So, respond to the stories that I share. That also tells me that you watched the lecture. So logistically, when you're on D2L, you can click on a video and fast forward through it, and it will show up as 100% complete on your end. But what professors get is how long you spent watching that video. So if I know the video is 35 minutes or an hour, and it says video watched, 2 minutes, even though it shows that you completed it and gives you that 100% completion, professors see how long you watched the video. So I don't want to be that guy who emails students, says, it looks like you were only watching this video for 2 minutes. Don't make me be that guy. I don't want to be. Watch the videos, watch the whole thing, take your time watching them. So, so this first one is a documentary. It's a short documentary on being sane in insane places. So the article we read, but I posted it this week because I didn't want to give you all the answers, before you read the article. But it is interesting. And, it's kind of like a little documentary on that article that you read. And and then the main thing I want to focus on tonight is the assessment process. And I moved through an actual assessment that I used to use for an agency that I worked at. And I did not use the most recent one for a specific reason. And I'm going to show you that reason in the notes. So let's see. session notes and assessment process. That's a video. That's on mandated reporting, move through the PowerPoint, contents of a good record, RX scribbles. So how many times did you look at a prescription, even if it's your own prescription, and wonder what all those abbreviations meant? So that's what this does. It just gives you all the abbreviations for prescriptions. So for instance, when I see a client, one of the things I talk about in the assessment process is we have to write down what medications they're taking. Here's the problems with assessing the medications that a client is taking. So the first thing is that they might have multiple doctors. They might have a heart specialist, and they might have a general practitioner, and then they might have a psychiatrist. And those, all their doctors, they don't communicate with each other. In fact, probably the people that know the medication best is if they submit everything to one pharmacy. But pharmacies won't release any information. It's got to come from the doctors or from the client themselves. So the problem is, if we say, what medication are you taking? They might only give us psychiatric medication because, we're therapists. They might think we only want to know about psychiatric medication. But one of the biggest problems with people coming to the mental health system is that so many medications for regular physical problems, not emotional problems, but just general physical problems, have so many side effects that affect our emotions and our cognitive abilities. So, if somebody is, for example, if somebody's taking heart medication, that's a big one. It could really affect how alert we are. It could affect our anxiety. It could make a person more anxious. People could lose their affect. There are so many side effects with medications. I'm sure you've all seen those advertisements for medication. Half the advertisement is side effects. And, and one of them's usually death. So that wouldn't be good. So what I ask patients for, I just ask them to bring in all of their medication bottles. And then I record, because the patient doesn't know how many milligrams or how often, or so it's hard for them to remember these things, if they can even remember the names. So if they're taking 5 or 6 different medications, I just have them bring in the bottles in a bag, and so I can write down the dosage, how many times a day, what the primary name or the generic name is of the medication, and both physical and psychiatric medications. All right, here's the other problem with assessing medication. So I had a client, I was seeing the child of this client. But one time the parent came in and she said that, she looked upset. So I asked, what's wrong? What's going on? And she said that, she was on the borderline of kidney failure and was having some liver problems. And so I just asked some basics, and they couldn't figure out what was causing it. That was the thing. And So soon she would have to go on dialysis and apply for a kidney transplant and everything else. And so I started asking questions because I'm curious and why they couldn't figure out what was going on. So the first thing, of course, we ask about is illegal drug use and alcohol. And she didn't use anything. And I believed her. And, and I asked about any type of physical medication or psychiatric medication. And none of them had kidney or liver failure as a side effect. And she was very young, and, her child was young. Um, and so then I'm like, okay, can you just walk me through a day? And she had disclosed previously that she had lost one of her parents and she was grieving that loss. And so I said, okay, what happens from the time you wake up, and give me a normal day until you go to sleep? She says, well, I get up, put the kid on the bus, make breakfast, put the kid on the bus, and then I go back to bed and she sleeps all day. I'm like, oh, well, what do you do at night? And she says, well, I sleep all night too. And I'm like, how do you sleep all day and all night? Because eventually somebody wakes up, unless they have like narcolepsy or something like that. And she says, oh, well, I take a lot of Tylenol PM. And so, you know, everybody thinks that, the opioid epidemic is one of the reasons for so many overdoses. But Tylenol kills more people than opioids every year. And um, and alcohol kills more people than Tylenol. And tobacco kills more people than everything. So what people don't realize is if they're taking something that is for sleep, so for instance, Tylenol PM has both acetaminophen and Benadryl in it. I guess the word is diphenhydramine. But the problem is, it's really easy to overdose on Tylenol because people might, let's say you have a cold and you take cold medicine. Well, cold medicine usually has acetaminophen in it. And then they take a couple extra strength Tylenols because they got a headache and their head hurts. So actually they're taking, 200% of that dosage of allotted Tylenol. So, and they might do that for 2 days straight because they don't realize it's already in the cold medicine. But she had been taking Tylenol PM just to sleep. And she could have just taken Benadryl, but Tylenol now advertises that it is a sleep aid, and you really don't need acetaminophen to sleep. All you need is the Benadryl part. So she had been going through boxes of this over a few weeks period. And, so I'm thinking, well, I'm pretty sure I know what's harming your kidneys. And so the whole point of this story is that when we ask what medications people are taking, they don't include over-the-counter medications in their answer to that question. So we have to specify what over-the-counter medications are you taking as well. What's happened is that insurance companies have advocated for a lot of the prescriptions to be allowed over-the-counter status so that insurance companies don't pay for over-the-counter medication. They only pay for prescriptions. So let's say famotidine, Pepcid. Pepcid used to be a prescription, but if you can now buy it over the counter, then the insurance company no longer has to pay for it. And that's happened with countless prescriptions. So Imodium used to be a prescription medication. Imodium is actually an opioid derivative. One of the side effects of opioids is constipation. And so Imodium is for diarrhea. And so that's why it works. But it's actually an opioid derivative. You'd have to take an awful lot of them to get a buzz, and it really wouldn't be good for you. But now it's over the counter. It used to be difficult to get that prescription. And but now you can buy it over the counter. So countless medications that used to require a prescription are now, and they're pretty potent, are now over the counter medications. And when you ask somebody about the medications they're taking, they don't include over the counter medications. A lot of times they don't include both psychiatric and physical medications. All right. So the last thing I want to point out in the assessment process is, and I'm going to show you, okay, so this is the assessment example I use in the video. So the reason I used an old, and these are notes I took, what to include under the presenting problems. These aren't actually written in an assessment, it's just blank. But I wanted to kind of tell you what to include in the notes. So the reason I chose an older assessment, none of this information changes. You're going to ask about the same thing. But what does change is the way you write out the diagnosis. The reason I used an old one is because if you're working for an agency and you pull somebody's file and they've been going to that agency for 15 years, or they got the records from like maybe a psychiatric hospital, they are going to have the old diagnosis in this format. So you're never going to have to write a diagnosis like this, but you're going to have to understand what it means when you see it in a client's chart. So that's why I included it. So before we look at this briefly, and it's also in the lecture recording, but I want to tell you, I want to elaborate on what the new diagnosis looks like. And there are no axes. So for the paper you're going to write the new diagnosis format. And the new diagnosis format is simply the code for the diagnosis, the number code, the title of the diagnosis, how long have people experienced the symptoms or the criteria, what is the severity of the criteria, mild, moderate, or severe, and which criteria are they experiencing and which are they not experiencing. That's the new diagnosis. It's so much more clear. And It's a lot easier to write and understand and read. And this old method with the different axes was very confusing. And people often didn't understand or learn or remember what the axes meant. But this is what is on each of these old axes, just so you know. But they don't use it anymore. I just wanted to give you the example in case you ran into it when you're in practicum or clinical field and a client may be older and they've been in the system for a while and you open up their chart and this is what you see. I just didn't want you to be confused. I wanted you to be able to recognize the old way of doing it. Okay? So that's the clarification. All right. And in the old way of doing it, they had the clinical syndromes, they had V codes, and then different axes are for different types of diagnosis. So axis 2, so you used to hear therapists say, oh, that person has an axis 2 diagnosis. So they would automatically know that it's either a developmental disorder, but most likely it was a personality disorder. Axis 2 was personality disorder. So rather than saying if there were other people around, rather than saying this person has a personality disorder, they'd say they have an axis 2 disorder. Most people wouldn't understand that. Axis 3, physical disorders and conditions. And they want that because they might be taking medication for those. Axis 4, severity and psychosocial stressors. Maybe they're homeless. Maybe they're going through financial difficulty, whatever it might be. Maybe they just separated or got a divorce. Maybe they're experiencing grief and loss. All of those different kinds of stressors they would add here. One of the largest problems with the old way of diagnosis was the GAF, the Global Assessment of Functioning. You're never going to have to write this, but you will see them in charts. I would ignore it totally. And here's the reason. Every single therapist looks at the GAF differently. So I gave you an example, the Global Assessment of Functioning. If you look at this, for instance, the lower the score, the more impairment. Okay. So I just want to find an example. So right here, behaviors considerably influenced by delusions or hallucinations or serious communication. So suicidal preoccupation. Well, yeah, okay, that's 30. That's pretty serious. I would rate that a 30. But then it says, or inability to function in areas, stays in bed all day, no job or friends. That's not serious to the level of 30. You know, that should be 60, maybe. So that's the problem. Okay, you've got two different levels of severity. You've got suicide versus no job. It's a huge difference. And that's why the GAF was eventually invalidated because of these discrepancies within each scoring range. So if you find a GAF in somebody's record, I would ignore that. So I do have an entire lecture just on the assessment process. And I want you to pay special attention to that because you're going to be using that for your paper. Okay. And I included IEPs because you may be in school counseling. So you're going to see them in school systems. And then finally, once you get down to here, I start talking about various diagnoses. And the way this works is you go from a video lecture, that's my lecture, and listen to my lecture first. If you run out of time doing all these things, it is a lot of time. I realize that. It's a lot to do in a week. But at least watch all of my lectures because that's what I felt was the most important thing to teach you. And then start watching like the documentaries. Okay, that's a bonus. All right, but at least watch my lectures, take a quick look at the notes, and then start with the documentaries you think will be the most interesting, you know? Definitely, I ask you about the medicated child, which talks about medicating children. A lot of these videos I put on here to promote discussion. It doesn't mean I agree with them 100%, you know? So you've got the medicated child, but then you have adult ADHD regaining focus. You've got two totally different perspectives on that diagnosis. So if you're interested in ADHD, then watch those two videos. See the two opposing views on medication, and you can discuss that in your discussion board. And so like I said, I only picked maybe five different diagnostic themes, and I talk about them in depth. So there you go. You've got about, I don't know, 8 hours of other lectures and videos. Do a little bit each day, you know, but definitely watch my lectures. Okay, because that covers the most important thing. All right, let me stop sharing. Questions, comments? It's a lot of information. Any questions on what I shared with you in this class? Any questions about the information for this coming week or what you need to do? Your only assignment for this week is the other discussion board and to watch the videos, read a little bit of a book. The way I do it the way I did it when I was a student was I'd watch the lecture and I'd be looking at the diagnosis in the book at the same time. And that's the way I remembered the criteria, because as my professor was talking about the different criteria and telling a story, I'd be able to see it in the DSM. And it's just an easy way to read the book while you're listening to the lecture. All right, what else? What else can I help you with? All right, have fun. If you have any questions or problems, if a link doesn't work, please email me so I can fix it. All right, I will see you next week.
Thank you.
Thank you, Dr. Grafton. Or Grafton, sorry.